Doing the roll call.
Yes. Commissioner Chung,
Here.
Commissioner Chow,
Present.
Commissioner Guillermo. I will read the land acknowledgement. The San Francisco Health Commission acknowledges that we are on the unceded ancestral homeland of the Ramaytush Ohlone, who were the original inhabitants of the San Francisco Peninsula. As the indigenous stewards of this land and in accordance with their traditions, the Ramaytush Ohlone have never ceded, lost, nor forgotten their responsibilities as the caretakers of this place, as well as for all peoples who reside in their traditional territory. As guests, we recognize that we benefit from living and working on their traditional homeland. We wish to pay our respects by acknowledging the ancestors, elders, and relatives of the Ramaytush Ohlone community and by affirming their sovereign rights as First Peoples. And before we move on, Commissioner, if I may, just noting for those in attendance and the one person on the public comment line that we're instituting some new procedures today and also a new AV system, and there are going to be quirks and bugs in all of them, so please be patient and give respectful, constructive feedback if possible as we move forward. And folks on the remote meeting, please let us know if you have trouble hearing us, because we're still working with the sound quality on our end. You can email me if you are not able to get through. All right. May we move forward, Commissioner, on to item 2?
Please do.
Item 2 is the approval of the minutes of the Health Commission Finance and Planning Committee meeting of February 7th, 2023. I apologize. That's an error on the agenda.
I move approval.
Oh, and Commissioners, please speak into your microphones.
Oh.
Because we're now in.
I move approval.
All right, person on the line, if you'd like to make public comment, please press *3 now. *3. All right, with no public comment, Commissioners, I will do a roll call vote. Commissioner Chung?
Yes.
Commissioner Chow?
Yes.
And Commissioner Guillermo?
Yes.
Great, thank you so much.
The point of order, Ms. Morowitz, do we have to do the roll call vote now? I mean, from this point on?
You know what? We don't. And I'm in my mindset, no, all we need is an aye and nay kind of thing. So
Yeah.
yes, thank you for reminding me of that.
Yeah, well, I mean, it's
Yes.
more accurately documenting who said yes, but yeah.
Yeah, no, great. Moving
Thank
forward,
you.
that's what we'll do. Item 3 is the monthly contracts report.
Good afternoon, Commissioners. Can you hear me okay?
Get really close.
Sorry. Good afternoon. Nice to see you all in person. We have 3 items on the summary report for this month. The first one is from the San Francisco Public Health Foundation. Today we are requesting approval for a contract amendment with the San Francisco Public Health Foundation to increase the total contract amount with contingency to $5,522,000 and to reflect a new term of January 1, 2018 through December 31st, 2025 for a total of 8 years. This contract was previously approved by the Health Commission on May 1st, 2017. The contract will continue to support project management for the San Francisco Health Network Primary Care Services. The proposed amendment exercises the options authorized under RFQ 36-2017. Funding will continue to support the project fiscal management modality. The annual funding amount is $715,000. The San Francisco Public Health Foundation will receive a 5% indirect rate in the amount of $34,000. The remaining amount of $681,000 will be used for direct services. The reason for the funding change, the department is requesting the approval of the total amount of $5,522,000 or an increase of $1,579,600 due to the following 3 changes. 1, additional funding for fiscal years 23-24 and 24-25 in the amount of $1,430,000 or $715,000 annually. And additional funding for 25-26 prorated at 6 months in the amount of $357,500. Also a decrease in the amount of $207,900 to the 12% contingency value applied in fiscal year 23-24 through fiscal year 25-26. The previous contingency was $422,400, and the current contingency amount will be $214,500. We have Anna Robert, the Director of Primary Care, who is here today, who can speak to the earlier submitted question regarding whether there are plans for the management of the PIP program to ultimately become an in-house function, as well as answer any other questions you may have.
afternoon. So good to see you all in person. Yes, so to answer, my name is Anna Robert. I'm the Director of Primary Care for the Health Network. This contract in particular supports the QI analysts at our on-campus clinics at Zuckerberg San Francisco General, which, as you know, we have a very close collaboration with UCSF. The medical director and all the physician providers are UC employees. These are also our 4 largest primary care clinics, where more than about half of our patients go for care. And these analysts, we have a quality improvement program across primary care. It's all integrated. We work very, very closely with these analysts so that we have consistency across all of our clinics. And really, half of our patients at these 4 clinics, help us really with both our San Francisco Health Plan performance improvement program, as well as our quality incentive pool, which together primary care brings in over $30 million a year in value-based care payments. These rules have been really, in this contract, has been crucial for maintaining continuity, especially in the last several years, the last 3 years with COVID. And just our staff being pulled and ensuring that we're able to continue with our population health value-based care.
Any questions, commissioners?
I did. I thought the question was whether this was going to be brought in-house at some point. I didn't hear an answer to that.
So, yeah, so I think the direct questions answer is that we do have an in-house program. They are part of it. I would consider they are a branch and part of this for our 4 on-campus clinics.
I'm sorry, I may be I don't. So you're saying no, it doesn't.
Well, so we can look to do that to get them moved into our budget.
It's just simple. There's no plans to do that.
Not at this moment in time.
Okay,
not
that's
at this
fine.
moment in time. Yeah.
Thank you.
So I just have one thing that I wasn't clear. So there are changes in like funding. So there's an increase, with including the contingency changes, but there is a line that says here the annual funding level remains the same. What does that mean?
Thank you, Commissioner, for that question. The annual funding amount is the same. The new funding is to extend the contract and to adjust the contingency amount as needed.
Okay, all right. So that I get it. Thank you.
Well,
Okay.
I'm not sure I understand that. It says here that the funding is $715,000 per annum, and that the previous amount was $715,000. So on an annual basis, it looks the same.
Correct. The annual amount is the same. The increased amount is to extend the term from 5.5 years to 8 years.
I see, you're talking about the term. Okay, we didn't hear that very well. And Mr. Morwitz, this doesn't seem to be activated. So let me go back to the other question, though, which Commissioner Guillermo was inquiring about. This is $750,000 a year, and while it's an important function, and obviously the reward is good performance and therefore more dollars coming in on the Medicaid program, right? It would seem that we should understand when a department feels that it could take on this capability. It'd be similar to like saying that, Laguna is going to need a QIE forever. And this sounds like we're saying the same thing here, and either they have very special expertise, because the Health Foundation is not HSAG in terms of its expertise. And so they're hiring people to help do this, which is very important, but is there a plan for us to do it in the future internally?
So we can definitely look into that
Okay.
and try to, we can look into that and try to plan for that.
Yeah, I mean, there
Yeah.
may be reasons that we don't have, the same capability as the Public Health Foundation, but at least from, their qualifications and credentialing, I don't think they match an ASAG, and we understand why ASAG is necessary. And if we're just doing, not just doing, but if we're doing QIE work, then I think that we should be looking to see what special expertise they really are having, and that's why we can't have it done within our own department.
Yeah, the other reasons I would imagine is, that you have done a cost analysis to look at, if there are any cost savings, to keep the services with the public health foundations, but we normally don't get that information anywhere. So if there is actually an analysis, that you can share with us, maybe it will be easier for us to understand the rationale.
So, commissioners, I'm noting this, and I'm going to follow up with staff, because I think the staff in the room aren't the people who are making these decisions and around that. But and we'll try to get answers back to you, and I'll loop in all the folks in the room.
Yeah, and you can go back and tell the powers that be that's what's missing sometimes. Thank you.
Thank you.
All right, Mr.
Next, excuse me, is that better without the mask? Next, we are requesting approval of a contract amendment with 18 reasons to increase the total contract amount with contingency to reflect an amount of $1,640,302. The contract term of July 1, 2020 through June 30th, 2023, a 3-year term, will be extended by 1 year to July 1, 2020 to June 30th, 2024 for a 4-year term. The contract was previously approved by the Health Commission on November 3rd, 2020. 18 reasons will continue to provide services to address chronic disease prevention through policies, policy, systems, and environment, or PSE level changes, projects related to sugary drink consumption and health equity through healthy food practices. The proposed amendment is authorized under RFP 26-2019. The Sugary Drink Distributor Tax, or SDDT, community programs funding will continue to support services under the modality of developed policy, systems, and environmental level strategies. The reason for the funding change, the department is requesting approval in the amount of $1,640,802, or an increase of $477,330 due to the following changes: additional general fund in the SDDT CBO awards funding in the amount of $500,000 for fiscal year 23-24, and a decrease in the amount of $22,672, the contingency value applied for fiscal years 23 and 24. The previous contingency amount was $124,658, and the current amount is $101,988. The annual funding level has increased by $150,101 due to additional funding for fiscal years 22-23 and fiscal year 23-24. Christina Goet, the program manager of Healthy Eating, Active Living Prevention Programs with Community Health Equity and Promotion, is here to respond to the earlier submitted questions of what groups of primary focus for this program may have been recommended in the future by the committee overseeing the SDDT tax funds, as well as answering any other questions you may have. And I apologize, commissioners, I don't see her in the room.
Oh, no,
I'm-
she's online, but
Okay.
Christina, can you start? Can you talk? I'm not sure if yes.
Yes, can you hear me?
Oh, hold on. So we're not able to hear you. Give me 1 second. One second. Okay, try now, Christina.
Can you hear me now?
Yes.
All right. Good afternoon, commissioners. Thank you for hearing this and having me today. I do want to reiterate that the populations that both 18 Reasons and Karasan are serving are priority populations that were identified in the legislation and by the Sugary Drink Distributor Tax Advisory Committee, or Soda Tax Committee for short. The committee isn't allowed to make recommendations on specific contracts. Staff did consult with 18 Reasons and with Karasan to determine what additional funds could support their work over the next year, and we negotiated these increases. So I think that's the succinct answer to the question. Happy to answer any other questions.
Commissioners, any other questions?
If I could ask a follow-up on that, if the soda tax is not, the committee is not making the determinations, I was just curious, you know, where the other programs are, and just in general then, these two were selected for a certain amount of money. Just a concept as to then what the whole breadth of the program is for our own interest to understand why then we've selected. And if it wasn't the committee that selected, who selected these and under what rationale?
Sure. So in this program, under this RFP, there were 5 organizations that were funded. 3 of those organizations are getting an extension of 1 additional year based on their performance and their movement toward getting toward those policy and systems changes. So all 3 of the organizations are getting an increase in funds. The third is not getting funding up to the $500,000 mark, which is why I think you're not seeing it here today. And so we had additional funding within this program with the 2 contracts that weren't being continued, and so we reallocated that funding to the existing the 3 contracts that are continuing for an additional year.
Oh, okay. I guess that's because we did not see the whole broad, way of allocating the money. And if you're saying the other, which is a smaller contract, is then also receiving but not before us, and then that would sound like everybody is getting their boats raised.
Indeed,
Which
that
is
is
fine.
the case.
I have no other questions.
Thank you.
Can we move on, commissioners?
Yes, please.
Okay, next we have the approval of a contract amendment with the Central American Resource Center, Karasan, to increase the total contract amount with contingency to reflect $1,487,000. The contract term of July 1, 2020 through 6/30/2023 for an initial term of 3 years will be extended by 1 year to end June 30th, 2024. This contract was previously approved by the Health Commission on January 5th, 2021. Karasan will continue to provide services to address chronic disease prevention through policy, systems, and environment, or PSE level change projects related to sugary drink consumption and health equity, as we discussed with the 18 Reasons contract. The department is requesting approval for the $1,487,000, or an increase of $489,080 due to the following changes: increase in the general fund sugary drink tax award in the amount of $500,000 for fiscal year 23-24, and an increase in the amount of $10,920 to the 12% contingency value applied for 22-23 and 23-24. Previous contingency amount was $106,920, and the current is $96,000. The annual funding level was increased by $200,000 due to additional funding for fiscal years 22 and 23. And once again, Christina, go ahead.
I had a question. It's sort of hard not to compare the two that we have in front of us. So on the detail of the program addendum that you provided us, there seems to be quite a difference in the number of units of service, as you call them, provided between 18 Reasons and Carecen. So I'm just sort of wondering how, it just sort of, to me, begs the question of how the program objectives, I guess, sort of even out, and especially since we don't have the other three as well to compare, these seem quite different. For instance, 18 Reasons doesn't seem to have a policy component to it, it's just a services component, whereas Carecen seems to have a policy component, less direct services. And so I'm just sort of wondering, how does that balance out in terms of the amount, because the amounts are pretty much the same for each of the organizations.
That's a great question, Commissioner. I'll defer to Christina, who's the program expert, to answer your question about it.
Thank you.
Yes, can you hear me?
Yes.
Still set up to hear me? Yes, okay. So these organizations are funded to work with specific different communities and have adopted very different approaches to bring in community input for the process. And so Carecen has engaged through a couple of different methods with their direct connect outreach, especially during COVID, and engaged them into the process. 18 Reasons is doing more programming. Their policy work is focused on the medically supported nutrition services through CalAIM, and working to bring that waiver where we can draw down funds for medically supported nutrition. So they're working on helping get San Francisco and on the path to implementing that program here in San Francisco. That's their policy work that they're working on.
So it would just seem that because they are so different and there is a different approaches, that being able to sort of determine what the success in relationship to outcomes, policy outcomes and change in behavior is, and I don't see where that becomes an evaluative part of the programmatic deliverables. And so I would be curious how we might measure that in the future, just to be able to see whether the approaches that each of the organizations are taking are actually bringing the results and the outcomes that are being that are planned or that are being projected.
Thank you for that. We can definitely take that into consideration as we build these contracts out in the future and continue to work with them over the coming year to make that more clear in the contract. I think that's partly what you're looking for.
Yeah, I mean, the interest I have is if these organizations know their communities and the services or the programs are being designed per the community's input, then you would hope then that they end up being, appropriate for these communities. And if they're not, that there might be an opportunity to adjust, change, do things more appropriate. It's not at all the question, the approach. It's to determine whether those approaches are actually the right approaches in the end.
Yes, understood.
So that's my question.
Yeah, and I think that's a good question, and I want to think a little bit about how best to address that. I think some of that is through work. We can work with our evaluator to work with the communities that the contractors are working with and do some assessments that way.
Okay. Just the last comment, I think because these were geared specifically towards a policy environmental change as opposed to just direct services, then you're looking for a different outcome in the end, right? Not just units of service.
Yes, that is.
I do think that there's some difference, though, actually, because the Carasan served specifically, you know, like Central Americans who are first and second generation immigrant families versus 18 Reasons just serve any low-income family. So I think that, you know, like the availability might be different. So, but it helps to delineate the differences so that we know specifically what makes Carasan unique. I think that that's the key word.
Yeah, exactly. I'm not trying to compare them to each other.
Yeah.
I just, you know, clearly, you know, there are differences in approach, and so whichever is effective for each of those communities, we want to be able to document and continue, right? And again, not to compare to each other. So I'm interested in how that actually creates the change that they're looking for.
Yeah. So for those who know me, I'd like to hear good stories and good outcomes, you know, from all the things that we invested. And I think that this would be a perfect opportunity to highlight, you know, how it makes a difference.
Well, I think that's why, you know, we're not getting the whole picture because there's also a third contract missing. So I know that, you know, individually we have rules about when you need to bring a contract to us, but when a contract does come and it really affects a whole program like the soda tax program does, somehow it would be nice to have put it into context so that we would also see what's happening with the rest of the community so that we can understand how all the pieces are fitting together.
Yeah, we get bits and pieces of information because the soda tax does come to the community and population health committees, but it doesn't really connect back to, you know, like how, yeah, exactly. So, you know, and when we tell stories, we want to make sure that, you know, like we tell from different dimensions of the story, right? So, yeah. So I think that if there's a way to connect those dots for us, we will get a better picture as commissioners.
And commissioners, if I may jump in, I believe Christina came and gave an update to you last fall on evaluations of this group of contracts. I think you had similar comments the last time a group of these contracts came to you around understanding, I think, the context of how they all work together. And so I believe, Christina, but wasn't that in the fall of last year that you came? Something like that?
It was the fall.
Yeah, so
Yeah.
you all could ask for something again, but I'm also reminding you that these are comments that you've had before, which are important, and to, for the department to continue to try to figure out how to address your needs in terms of information.
Over 100%.
Yeah, I think it would have been simple to have just said as an overview, sort of similar to how we are also going to be looking at the overall contracts programs, for example, that presenting 2/3 of the program, it would be helpful to have reminded us what Christine had brought to us and said it would have taken probably less than a paragraph to indicate, you know, this is the overall program. These are two that have very high costs that come as a contract. Here's a third one, and here's how each one works. And that puts us into context. And it's very similar also to us following construction and so forth. We're looking at the entire building 5 and then seeing what portions are happening. Otherwise, all that we would get is portions of building 5, and we wouldn't understand what we're talking about, you know, as the total picture. We're looking at the broader picture and where then the contracts fit into that. And our obligation then is to see how does that fit into the public needs and understanding all of, in this case, the soda tax people, the contracts and so forth. So I think that it's not a technical issue only, but trying to really understand, just as Commissioner Chung has said, it's the story as to what we are funding and how well are we doing with it.
Thank you.
We like
Good
to brag
perspective.
about how well the department is doing to our peers as well. So like, give us that opportunity, please.
We'll do, as we have these things that come in
Thank you.
small numbers or smaller groups.
Okay, I know, I'm like, I thought we were supposed to be the second one, why is this still going on? Okay, all right, okay, I think that's it, so I don't know if Dean is supposed to read this or me, but I just thought,
Is that that's the last one on the?
Yeah, so we now need to have a vote to include the contract report in the consent calendar.
And there are people in the public comment line, so if you all do a motion, I'll go to the public comment, and then we can come back.
Okay, can we have a motion, please?
So moved.
I'll second.
Great, thank you. And folks on the line, if you'd like to make public comment on this item, please press star 3. Star 3. Okay. No public comment. So Commissioner Chung, since we're back to the, could you do your normal thing to get the call?
Okay, so we have a motion and a second. For all those in favor, please say aye.
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 Any objection? Okay,
Fantastic.
motion carried.
Nice to hear the old ways back. Item 4 is a request for approval of a new contract with Haluna Health.
Okay.
Hi, this is Philip Coffin. I'm filling in for
Haluna Health,
Dr.
we have a
William.
request for approval of a new contract agreement with Haluna Health, working in conjunction with DPH CPHR, the Center for Public Health Research, to perform implementation of BLISS project. BLISS is Brief Longitudinal Incident Sentinel, which is a federally supported research project funded by a federal grant from the National Institute of Health. The total proposed agreement amount is $870,805, which includes $770,505 for program costs and a 12% contingency of $93,300 for the term of April 1, 2023 through July 31st, 2028 for 4 years and 3 months. The Brief Longitudinal Incident Sentinel Survey project is designed to work toward ending the HIV epidemic and mitigating other health disparities for persons who inject drugs, and to create data collection systems to be more rapid, representative, and responsive to this population at high risk. A question was submitted yesterday about how many contracts DPH has with Haluna Health and what is the total amount of these. I analyzed this, and DPH currently has 24 contracts with Haluna Health, with a total not to exceed amounts of these multi-year contracts is $69,471,000. And I'll send that list to Mark so you have that for follow-up. Haluna Health has had a waiver, and in regard to the performance, I learned that Haluna Health has had a waiver due to good standing from the citywide fiscal and compliance monitoring process for the past 2 years. However, this year, the Department of Homelessness and Supportive Housing is the lead department in the citywide fiscal and compliance monitoring process for this agency, which should be completed by the end of this fiscal year. Here to provide more program details and to answer your questions are Aaron Wilson, Senior Scientist and Director of the Trans Research Unit for Equity with DPH's Center for Public Health Research, and Dr. Philip Coffin, the Director of the Center for Substance Use and Health, who is joining us virtually and is standing in for Dr. Willie McFarland, Director of the Center for Public Health Research. And as well online, we have Adam Abate from the contract manager with the Haluna Health Program.
And if I could just announce to everybody, I'm learning this as I go, and if someone's remotely speaking, I have to go online and turn them up manually, and then quickly before anyone in the room speaks, I have to turn everything down so there's not reverberation. It's crazy. So if you could just remember that and have a pause in between. So who will be speaking first in terms of? Sure, okay, great. Thank you. Just so that I can figure out what to do with the volume.
Hi, everyone. I saw you just last week, so thank you so much for having me back. As you all know, we have a major issue around HIV prevention and care needs for people who inject drugs in our city and in Alameda County, so I presented those data. We were really lucky to be able to receive funding from the National Institutes of Health to follow up on precisely those problems, and the goal of this project is actually to do better real-time surveillance with folks in the community here in San Francisco and Alameda County and build interventions to address their prevention and care needs. That's the short of it. If you have questions, I'm happy to answer those.
Commissioners, questions?
It's not really our money, right? So it's NIH money that we are
Exactly.
doing the contract with.
That's right, yep.
Yeah, that's all I need to know.
Anything else, commissioners?
Well, I was wanting to ask about the number of contracts because that's from a different subject. It's this whole issue of looking at organizations. But I appreciate that we were able to have this type of contract and be able to do the study. So I have no opposition to the contract.
Yeah, we're more concerned about those that are actually supported by general fund, so that we know, like we are diversifying into the different kind of service providers and not just like keep putting money into one. So, but this is definitely, like a different case. So thank you.
Okay, thank you. Thank you so much.
All right, thank you. Oh, so commissioners, if you all could consider a motion, and then I'll check public comment.
I'll move approval.
Second?
Great. Folks on the line, if you'd like to make comment on item 4, you can press star 3. Item 4, again, is the new contract agreement with Helena Health. All right, so there's no public comment. Commissioners, please feel free to vote.
Okay, so we have a motion and a second. So for all in favor of this motions to add this to the consent calendar for approval, please say aye.
Aye.
Aye. Any objections?
Okay, thank you. We can move on to item 5, which is request for approval of a new professional services agreement with Nikos Chinese Health Coalition.
This is a request for approval of new professional services agreement with Nikos Chinese Health Coalition to prevent or reduce the impact of problem gambling through education, awareness building, and consultation. The total proposed agreement amount is $3 million, which includes a 12% contingency for the term of July 1, 2021 through June 30th, 2026 for a term of 5 years. This contract is retroactive due to the fact it was caught in a perfect storm of timing of several factors, particularly due to several staff vacancies in the contracting section in the last year and a half, several of which were unplanned, resulting in an extremely long span of time for this contract to be processed and eventually approved by the city attorney recently. The goal of the Chinese Community Problem Gambling Project is to prevent and reduce the negative effects of problem gambling through education, awareness building, and consultation. I said that already. And the goal of the Culturally and Linguistically Appropriate Services Advocacy, or CLASS Act, is to reduce health disparities and to improve health outcomes for San Francisco's diverse communities, with an emphasis on Asian Americans through the promotion of the Office of Minority Health's national standards for CLASS. While this is a new contract, it is a continuation of previously provided services which required resoliciting. Moving forward, I'd like to know that we will include summary details from prior EOCC monitoring reports in the performance backup document that you get each month with these documents. So apologies for not including that, but we do have some information to share with you based on that question. I do have some information from Jenny Hua, who's the Older Adult Services Director with the Adult and Older Adult System of Care at the Behavioral Health at BHS, to respond to the previously submitted questions regarding past performance and the split of funding between the two components. From Jenny, she commented that Nikos is named after its 5 founding agencies: Northeast Medical Center, Independent Physicians Association, Chinese Hospital, Unlock, and Self-Help for Elderly. It is a public-private community partnership of more than 30 health and human service organizations. The budget for the two components of this contract is $382,106, with the gambling project annual amount being $195,021, or 51% of the funding, and the funding for the CLASS Act is $187,000, or 85, or 49%. The Chinese Community Problem Gambling Project developed as a result of the Chinese Community Health Study in 1997, with 70% of the 1,808 Chinese Americans in the study identifying gambling as a problem. The project provides media and community-based education, advocacy, and outreach to problem gamblers, families, and support service agencies to identify, prevent, or reduce the negative effects of problem gambling. Nikos engages the community through Chinese TV, radio, newspaper, street fairs, schools, and various social media platforms. Since its contract with DPH in 1998, NECOS has consistently exceeded its contracted units of service target between 101% to 114% from 2016 to 2021, and received 5 out of 5 on performance objectives. This is a continuation of past programs and not an expansion, as I said earlier. The Class Act, or Cultural and Linguistically Appropriate Services Advocacy Consultation and Training Project, started in 2015 as a statewide collaborative to support health and social service providers in providing more culturally responsive services for San Francisco's diverse communities. The project was developed in accordance with the 15 enhanced national class standards, which seek to advance health equity, improve quality, and eliminate healthcare disparities. The Class Act's intended project promotes cultural humility, responsiveness, anti-bias, anti-racism by providing consultation, advocacy, and training, as I mentioned. The question about the 500 client reference in the document, that is the unduplicated client target. Jenny Hua clarified that the actual UDC was 1,576 clients in fiscal year 2021. And they also exceeded the contracted units of service by 105% to 111%, as stated earlier. Jenny was unable to be here in person today, but she is available virtually to answer any questions you may have, as is Kent Wu, Executive Director of NECOS. Thank you.
Commissioners?
I just had one question. So given that this contract is being put in front of us several years behind, does that mean that funding has not been made available to them, where they cannot bill and get reimbursed?
They will be able to bill retroactively once the contract.
So we're talking about 2 years worth of arrears billing.
About a year and a half, yeah.
Okay.
7 months, yes, and it was just recently approved by the city attorney. As you may know, we have fairly recent requirements around retroactive contracts, which we're trying to catch up with and stay on top of. This contract was just recently approved by the city attorney, and that is why it's approved today.
Okay. I'm just hoping that in the future we're not, these nonprofit organizations are dependent on a flow of cash, and if they're doing the services and we're taking 2-3 years, that's really detrimental to continued operations.
I agree, and that is something we're working on at every level.
Yeah, maybe we need to have another conversations, because I think that at the onset of the COVID lockdown, like we had the conversations with Mr. Wagner also, like to look at how to streamline some of these process so that, the money wouldn't hold up to go to where it needs to go. Like, because, during that time, we also see a lot of backlog into like contracts and RFPs. So I think that this should be part of that conversation, so that, like, even though, like they get to bill retroactively, but they have to be able to ride the storm to like get to the point to bill. So yeah, like Commissioner Guillermo says, like let's try to find a ways to prevent that from happening in the future.
Absolutely. I can assure you it's become one of our highest priorities in moving forward. It's just taking care of a few of these that have been caught in the flex in the last year.
Are you sure that they, we've had retroactive contracts where people have actually been paid before the contract is really completed. So are you sure that, I can't imagine how NECOS sponsors nearly $500,000 a year without having had any cash, knowing that NECOS has no cash. I mean, they're a coalition of 30 organizations. So I don't see how they could have carried this out without some sort of funding. So are you sure they didn't get any funding in advance or something?
Not that I'm aware of, Commissioner. I can check into that.
Yeah, I think that either way it's kind of problematic, because the city attorney's office didn't approve this until recently. So that means that if we have been funding it, like we...
That's the other problem.
That's the other problem, yeah.
But I just can't see how they were able, and if that's true, there's, it really is a strain on this organization to do that, and I think that needs to be looked at. My question, though, is on the Class Act. I mean, I understand the gambling, and I'm really pleased that we're, as a city, continuing to really sponsor this problem. And it would be nice to see what results we've had, because it's now 20-some-odd years that we've been doing this. So I think on the gambling side, it would have been nice to be able to understand what results are coming up. I mean, notwithstanding the fact that if they got no money, I don't know that they can have any results. But I'm very curious, is the class effort related to gambling and that's why it's in here, or is that a separate initiative? Because the way it sounds and written, it sounds like there are two different initiatives, although it comes under the term of the gambling initiative.
I'll defer to Jenny to answer that question, who's more
And
familiar with
Jenny,
the
give me a
details.
second to turn up the sound.
So we'll pause for a second while Mark cues that up. As written, I would imagine they're separate but connected.
Okay, Jenny, you can begin. Make sure you unmute yourself.
Yes, Commissioner, can you hear me?
Yes.
Yes, thank you. I'm sorry. Yes, these are two separate programs. The problem gambling started in 1997, and the Class Act started in 2015. It started off as a statewide collaborative. We received funding from the state to support health and support services on these cultural responsive services, but then the funding can discontinue. But the service was so great that the city decided to continue this services through NECOS. So that's why it's put in the same contract. It's two separate services.
So it's really a separate program not related to gambling?
Cost is not related to problem gambling. Problem gambling is outreach to the China community about the detrimental effects of gambling, and class is really going out to the different agencies and working with them to develop a plan to better work with the clients to achieve cultural humility and ensure that everyone gets fair treatment in healthcare. And also Kenneth Wu, Director of NECOS, is online. If you want to add anything, Kent.
I don't see Mr. Wu on the line. Oh, I'm sorry. Here, Mr. Wu, I just press *6 to unmute yourself. And please begin speaking.
Can you hear me?
Yes.
Oh, okay, great. I'm sorry, what was the question?
The question was what class does, and is the target related to gambling, or it sounds like it is related to trying to bring class to your different community organizations. So
Yes, that's it. So there are two separate programs, and Class Act is entirely different. It is to bring the cost standards to service providers, also future service providers. So we provide trainings to clinics, to social service agencies, also to medical students and other folks who are entering the profession. The description that Dean gave was a good one. All around anti-bias, anti-racism, all to bring about equity and good health outcomes for folks.
So they are two separate programs, even though under one title.
Yeah, so the tendency for the Department of Public Health is to lump contracts together. I guess that's for simplicity on their end, so that billing comes under one invoice rather than separate ones. But they are rated separately. They are treated differently also.
I think in the future, and this doesn't relate just to NECOS, we've asked in the past and gotten behavioral health to give us the results, the outcomes. And it would be really nice to have an understanding of how well this program is working, especially since it was initially state-sponsored in 2015. And have we really achieved, and be able to celebrate the achievements over these 7 years as we continue to fund it. So this is again asking for outcomes. For us to be able to understand the context, and it's not just that they're doing, and we know that, or at least I know Nikos does heroic work with limited resources, and it sounds like it's even less resources if we are not paying them during this retroactive period. But it would be nice, again, as Commissioner Chung said, to be able to celebrate what we're doing and be able to then validate the continuation of these contracts. So it isn't just behavioral health where we are getting good reports back, but on these others that it would be nice to understand the outcomes.
Thank you, Commissioner. I can follow up with Jenny. And,
Thank you.
Mr. Wood would get some
Yeah.
information on outcomes. That too. And through Mark.
Otherwise, I would, if there were no, is it appropriate to move the recommendation to approve
Of
the
course.
contract?
I'll second.
Great, and I'll check public comment. Folks on the line, if you'd like to make comment on, where are we? We're on item 5. Please press *3. All right, seeing no public comment, commissioners, please consider a vote.
Okay, so we have a motion and a second for, to add these contracts to the consent calendar for approval. All in favor, please say aye.
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 Any objection? Okay, so we'll add this to the consent calendar. Thank
Thank
you.
you. Item 6 is a request for approval of a new contract with CarePort Health LLC.
Okay, this is approval for a new contract with CarePort Health LLC in the amount of $1 million to secure patient choice referral list services for the department. CarePort software will generate a choice list to be used by DPH patients that identify skilled nursing facilities and home health agencies that have both bed availability and will accept the patient's payer. This will be done through an interface with Epic, which allows for clinical documents and patient demographic information to be assessed and attached to referrals that can be electronically sent to qualified providers. I'm here to provide more program details and answer any questions you may have. Are Glenn McClintock, Director of Social Services, Medical Social Services Division, Department of Care Coordination at Z's, San Francisco General, as well as online we have Dallas Elmore with CarePort LLC who's joining us virtually. And they will address the previously submitted question on how this program will work more effectively in finding placement and how it will work with preferences of patients and their families. Thank you.
Good afternoon, Commissioners. My name is Glenn McClintock. I'm the Director of Social Services at Zuckerberg San Francisco General. In regards to your question regarding how this might help patient flow, this is a product that many other hospitals have in the Bay Area, and it's going to be very important for us to provide the most efficient discharge for patients that are going to skilled nursing facilities, as well as home health agencies. Recent data has shown that the second largest discharge population besides home is to skilled nursing facilities, and the need for home health continues to grow as borne out in recent data as well. Currently, our nurses, our care coordinators, spend 1 to 2 hours sorting through home health agencies and referring or calling skilled nursing facilities to determine which of those facilities accept patients. And our information is somewhat limited and based on our experience historically with the San Francisco Bay Area. CarePort would allow us to immediately put patient information, including insurance or special needs of that patient, and refer to a variety of skilled nursing facilities within a designated demographic area, thus cutting down the turnaround time dramatically. The other piece is that for home health agencies as well. There are so many home health agencies that that same process becomes very arduous, and we often end up relying on the home health agencies that we normally work with and not being aware of other services that may or may not be available. The initial estimates of this looked that we could decrease our decrease bed days by 0.2. And just looking at our fee-for-service Medi-Cal population, that comes out to about $361,000 in savings a year. The other thing that is really important for us with this product is that under the IMPACT Act, we're required to give patients a choice list and make sure that we appropriately document their preference for a skilled nursing facility or a home health agency. Our ability to do that is somewhat limited by our knowledge and our lack of access to the data that a system like CarePort can provide. And also, CarePort would allow us to more comprehensively provide a list, present it automatically and even by through a patient's phone for them to evaluate and return their preference immediately, thereby saving time. As you know, I mean, at this point, patient flow is everything for us, and I truly believe this is going to be an important product to help us move forward and help address those patient flow issues at the hospital.
Commissioners, any questions or comments?
So this is a software program, not people, and our nurses then go into the software program, and it then tells us what's available for this particular patient?
Yes, it's integrated into Epic, and then a nurse, for instance, would go, they'd enter the patient data, their insurance data, and it would do a search. It would provide a list of those skilled nursing facilities that person could apply for, and then it would generate referrals to those agencies. In turn, it would provide a list or send an electronic list to the patient for them to note their particular preference for that placement as well, or for home health services.
Oh. Well, it's quite a database then.
It is an amazing database, and I have to say, you know, years ago I worked at Brown and Tolan, and we had all of our ancillary grids well established, and it was it took a lot to keep those established. With CarePort, I think the other thing that's important and hard to stay on top of is that facilities take different types of are constantly changing the insurance that they accept, and home health agencies in particular, it's really difficult to know who's accepting what service. And again, I think this is going to be vitally important to help us be able to not only meet the needs of the requirements of the IMPACT Act, but to help people discharged to skilled nursing facilities and to home with home health as soon as they're no longer acute.
Seems like a very small amount of money for all
I
the
was
work that
thinking
we're
the same
talking
thing.
about.
But, you know, I'm glad we've found this service, and I'm really looking forward to seeing how effective it ends up being. I'm assuming it's probably using some sort of AI or application or software in order to keep it updated, and I'm glad to see that the integration with Epic is already in place, so
Not to oversell,
promising.
but it accesses the Medicare quality data, which we're also required to
Even better.
Provide to patients, and that again changes quite frequently and is really difficult to stay on top of.
Be looking forward to an update at some point on how effective it's really reducing the length of stay as it is projected, because that's a big. Even if it sounds like it's a small amount, you add all that together and it makes a huge difference. So looking forward to that.
Are there any other questions? If not, can we have a motion?
I'll move.
A second.
And I'll check public comment. First on the line, we're on item 6. Please press *3 if you'd like to make a comment. No hands, Commissioner, so please consider a vote.
Okay, so we have a motion and a second. All in favor, please say aye.
Aye.
Any objection? Okay, we will add this to the consent calendar for approval. Thank you.
so much, Commissioner.
Item 7 is request for approval of a new contract with Emerson Digital Cold Chain, Inc., DBA Cooper Atkins.
Okay, this is approval for a contract with Emerson Digital Cold Chain Incorporated, DBA Cooper Atkins, in the amount of $645,468 to secure maintenance and upkeep services of the network of TempTrack temperature monitoring devices currently in use by the Department of Public Health for the term of March 1, 2023 to February 29th, 2028, for a total of 5 years. The department is purchasing maintenance services for the TempTrack temperature monitoring network installed at ZSFGH in Laguna Honda Hospital. It was purchased and installed 13 years ago. The TempTrack network, it is made up of dozens of individual devices that together monitor the temperatures of many separate appliances and storage units dispersed across the hospitals. The networks help alert DPH staff to any unacceptable temperature variances in environments where perishable or otherwise temperature-sensitive medications in stock are kept in storage. We have available Greg Chase, the Director of Facilities at ZSFG, and Jonathan Ganick, Healthcare Channel Director West for Emerson Digital Cold Chain, who are joining us virtually and will provide more program details and answer any questions you may have.
Let me turn up the volume, guys, before anyone says anything. Okay, Mr. Chase, do you have anything to add?
No, Mark, we're all good here. This is Commissioners, this is Greg Chase, formerly of San Francisco General, now coming to you live from Laguna Honda. So we use TempTrack both at Laguna Honda and at San Francisco General, have for a number of years.
Commissioners, any questions, comments?
Commissioners?
None.
I don't think that we have any questions for this one at this point. Unless
sorry,
Commissioner Chow has any questions.
No, it sounds like something we should have done a long time ago. But anyway, I'd move acceptance, a recommendation to the commission for approval.
I second.
All right, person on the line, if you'd like to make public comment on item 7, please press *3. *3. I see no hands, Commissioners.
Okay, so all in favor, please say aye.
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 Any objections? None. So we'll add this to the consent calendar.
Great, thank you.
Commissioners, thank you so
excited
much.
that we finally get to Ms. Louie, who's been like waiting patiently for like 2 months for this to happen.
Thank you.
Thank you, Mr. Goodwin. And Ms. Louie, the presentation is on the computer, old school. And everyone, just for you to know, we're having sound issues with the 4 o'clock meeting, and if we can end as close to 3:30 as possible, then that team has to come in and troubleshoot before the 4 o'clock. So I know we've got this going on, but please keep that in the back of your mind. Thank you. And please speak as close as you can to the...
Right. Good afternoon, Commissioners. Jenny Louie. I'm very pleased to provide this old school presentation in person. It's just like old times. So switching gears, I'm pleased to present our second quarter financial report to members of the committee. I was about to say next slide, but
Just arrow down.
okay. So just overall, the second quarter report compared to the first, we're trending on pretty much the same level. A revenue deficit of $15.2 million projected for the current year. This is primarily due to reduced census at Laguna Honda during the recertification process as we pause new admissions. And some of this is partially offset by favorable revenues at ZSFG, which nets 15.2 deficit on the revenue side. On the expenditure sides, overall across the department, we are expected to be on budget, but I will note that ZSFG is projected to be $20.9 million over budget. This is driven by several factors, and there's just no one thing, but it's in part due to inflationary costs, as you know, as markets I think are still adjusting post-pandemic, and so costs are increased. There's also increased registry cost based on workforce. as well as an overall increase in census at ZSFG, which obviously just because of that increased service level drives costs. And I will note, just looking at some of the census data that we've seen, like on average, ZSFG is about 6% higher in terms of its daily census than in prior years, which is in part a part of this story. Laguna Honda Hospital, we're projected to be $2.8 million over budget on the expenditure side, and this is really primarily due to the recertification efforts we have going on. And again, as I mentioned before, overall this overspending will be covered with other savings in other areas of the department. So on the expenditure side, at this point, I'm projecting to be on budget. I will note that these figures are based off of the 6 months of actuals, which is basically through December of 2022. There's always a little bit of a delay because it takes us about a month to receive the final billings and payroll from December, the analysis and working with the controller's office, and then the writing up and calendaring of these financials. And so I'm bringing these to you in March, but just note that this is based off of 6 months of actuals. And so much could be changed depending on Laguna Honda's recertification process. Our hiring process, as we added over 400 new FTE as part of this budget, as part of the budget process for this year. And currently we're projecting about a 1.9% salary savings for this through the end of the fiscal year. And then last but not least, should there be any changes in COVID service levels, it could impact our financials as well. So going to the high-level summary, as I mentioned before, you see this 15.5 of good news over at the general, the shortfall at Laguna, some minor variances across all the other divisions for that revenue shortfall that you see here. And on the expenditure side, we're pretty much projected to be balanced, again, with some of the overages offset by savings in other divisions for this net shortfall of 14.8. And we'll talk about the management reserve at the end, but should this $14.8 million deficit still persist through the end of the year, we will make a withdrawal from the management reserve to balance the shortfall moving forward. So going into the details, Zuckerberg San Francisco General is projected to be $15.5 million favorable on the revenue side. 49 million of this is related to favorable net patient revenues. I will note that the primary driver of this increase is that fee-for-service conversion that I mentioned to the commission and was included as part of our budget proposal moving forward, and is a significant portion of our revenues where for a portion of our patients, for inpatient stays at San Francisco General, we are converting from a capitated model to a fee-for-service model that improves our revenue because we are no longer bleeding some of the out-of-network costs that was being deducted from our capitation. And I will also note just on that second line there that Medi-Cal managed care supplemental revenue, that $11.1 million shortfall is actually also related to that conversion, because as we move from a capitated model, we did lose some benefit from the EPP funding pool for the state. And so I just wanted to note that it's not a full-blown net 49 million that we receive, but it's really being offset slightly. I think I just did this in consistent order with how we state the numbers in the financials, but I probably should have coupled them together. Unrelated, under the global payment program for uncompensated care, we are seeing a shortfall of $21.8 million. And again, because GPP is a program related to uncompensated cost of care, what we're suspecting is actually some of the improvements in Medi-Cal eligibility as proposed by the governor. First, with the 50 and over now being eligible for Medi-Cal regardless of documentation status, an expected shift for the rest of the adult population subsequently is a good thing. But when we are looking at a payment program for uncompensated costs of care, because they're no longer uncompensated, we suspect that we are not earning the points at the threshold that we would normally suspect as more people transition than expected. So this is something that we will watch over the course of the year. We did make a minor adjustment in our budget to reflect this, and so hopefully we won't see this shortfall moving forward, but something we will watch as more people do transition. Again, there's obviously a lot going on with Medi-Cal eligibility nowadays, but overall, this is in some ways a good thing. And then moving down to the health plan capitation, our Healthy Workers Program, we've had some rate increases over the last 2 years, and this is essentially that 10.3 million as a result of some of the improved rates that we are getting for that program. The Graduate Medical Education Program, GME, where we get compensated for our costs, as being a teaching hospital, is rendering us 3.4 million this year. We also have a shortfall in our 340B specialty pharmacy program. This is really a delay in a budget initiative that we had, where we're hoping to be revenue neutral on this and generate additional revenue related to expanding our specialty contracts and receiving accreditation. For this, there has been delays in getting that accreditation, that expanded contract. But I hope, in speaking with Dave Woods, our director of pharmacy, he's working on that in earnest, and hopefully by next fiscal year we will not see the shortfall. On the expenditure side, there's a $20.8 million shortfall. Salary and benefits are essentially expected to be on budget, but when we look at non-personnel services, 16.9 million. And some of this is driven by registry. Some of it is driven by additional COVID testing costs that were not included in the budget. And I think there's also a persistent shortfall in some of our language and translation services that are showing up as a shortfall overall that adds to that 16.9. On the mats and supplies, we're seeing, there's also some testing costs related to mats and supplies, as well as some overages, again, expected, as we understand it, due to some inflationary issues, as well as higher census. We do have some savings services of other departments overall across the department. These work order savings is really around workers' comp, which is a good thing because that means that we have fewer claims on workers' comp because our workers are remaining healthy. Moving over to Laguna Honda, as I mentioned before, the revenue shortfall due to the lower than budgeted census as we are pending recertification. And then on the expenditure side, 2.8 million unfavorable. It includes 4.5 million of non-personnel services. And I will note that you will note that there is no salary variance. And a portion of this is due to the fact that we actually surplus transferred $10 million of salary and fringe savings into the non-personnel line to revise the budget moving forward. I will say ordinarily these are transactions that we do at the end of the year to rebalance the entire department, but given the appropriation authority at Laguna Honda and the need, we did do this in the second quarter of this year, which is a bit unusual, and I did want to note that. But again, this is all within our total appropriation authority and approved by the Controller's Office. And then again on Laguna Honda, small savings, not so small, but savings on our workers' comp work order with the Human Resources Department. Moving over to behavioral health, revenues are basically net more or less on budget. I think we overprojected patient revenues and short dwell and behavioral health Medi-Cal. A portion of this we are pending. We're looking at how the state is adjudicating some of our prior claims. This figure may increase over the course of the year because we believe that they're delaying some of the review, so we're not actually seeing the approved claims at the level that that we would expect, and so we hope to see some improvement in that. But this is we're basing this off of the claims, the actual claims that we do have already. 2011 realignment, though, is balancing that shortfall out. This is again the state sales tax related to realigning behavioral health services. Sales tax is coming in stronger through the state, and through the state formulas, we receive a portion of those increased revenues. We also have a slight shortfall in other state revenue that I believe is due to a prior year recognition of revenue related to the school district. On the expenditure side, there's salary and fringe savings of 7.1 million. This is due to the delay in one-time hiring of the new positions we have, as well as 3.8 of non-personnel services. On the primary care side, we're projecting it to be, the revenues to be pretty much on budget, some slight variances between patient revenues and capitation. On the expenditure side, we're expecting to be 1.9 million favorable, primarily as related to salary and fringe savings with a little bit of that workers' comp savings that we see as overall. For jail health, we are projected to have a $800,000 savings. This is really related to, we've got salary and fringe savings on one hand, but at the other hand, we are increasing our registry contract costs by 1.7 million, which offsets some of that good news. But again, also some savings related to workers' comp. For the health network, our revenues are 3.2 million short. There's good news at Health at Home with 600,000 improvement. It's offset by a reduction in Healthy San Francisco participant fees, as well as a shortfall on CalAIM, Enhanced Care Management program. One of the things is that we noticed is a slight decrease in enrollment and capacity in this program compared to what we would expect in budget. Also, due to how the rates were originally set, it was through the health plan, it was a bit of a challenge to actually document some of the services that we receive, because the initial requirement was to qualify for the benefit of enhanced care. We had to prove a minimum of 3 touches in a given month to show that we were actually providing that enhanced care. The health plan has since changed their rate model so that we don't have to have 3, but we can document 1, which facilitates our ability to bill for the remainder of the year. So I do not expect this shortfall to persist. Also, as we continue to fill our vacancies around care coordination, I would also expect our capacity to grow. So I believe this will be a one-time shortfall that we'll continue to see through this fiscal year, but I expect this to improve and hope to be on budget by next year. There's also a minor shortfall in the city option fees. Let me see. On the expenditure side, again, 5.5 million of salary savings due to delayed hiring, offset by 3 million of non-personnel savings. This is due to a contract that we have to purchase additional beds through Chinese Hospital to support patient flow, while Laguna Honda is no longer accepting, pausing on new admissions. And on population health, shortfall in patient revenues, we are still working through an issue with Public Health Lab and Adult Travel Clinic. I expect this to persist over the remainder of this fiscal year. We are working, Population Health is working with IT and operations to determine how to recover some of the billing. A portion of this is also just related to the model around the adult immunization and travel clinic, where we are just seeing overall decrease in international travel, large companies sending, their workers overseas. And so I think that we are also, some portion of this will continue to persist. And again, it's a question of the model of the services we provide moving forward. On the expenditure side, savings due to hiring delays within population health. And last but not least, public health administration and operations, a slight uptick in vital records fees, 200,000 and 4.5 million of salary and fringe savings. As I mentioned before, the projected shortfall of 14.8 million, should it persist, we would make a withdrawal from the management reserve. At the beginning of the year, we had 123.9 million available to us at the beginning of the fiscal year. Should this deficit materialize, we would make that withdrawal and still have a remaining balance of just over 109 million available to us, or it's about 4.4% of our 2-year budgeted revenue. In terms of the COVID response budget, we are projecting currently a $5 million surplus, primarily related to prior year savings, as this is a continuing project that rolls over. And we had some encumbrances from the prior year that we rolled over, but did not actually receive invoices to pay against, so that realizes some savings that's available for us to carry forward to support our COVID response in the future. Again, most of this is related to the 700,000 related to closeouts in our isolation and quarantine hotels. We've got 1.7 million projected savings in the community project, and then 1.9 million in vaccination and 800,000 in savings based on current trends. And again, this is the 6-month report. What I'm seeing in the third quarter, I'm not expecting a significant surge or uptick, but that will be for the next quarter's report. But we are at this point not assuming any additional surges for the remainder of the year as part of these projections. So with that, that completes my report. I will note I did have a question from a commissioner regarding noting the shortfall, like what is the perceived shortfall in Medi-Cal revenue. And what I would actually say is overall, our revenues are still growing, with the exception of the Laguna Honda census issue. But if you compare year over year, our budgets are growing. But I think what you're seeing is that ordinarily we see these variances that tend to be much higher in terms of budget to actuals, where last year I know we closed with over 100 million of additional revenue compared to budget. I think that this is in part due to the fact that we aggressively assumed revenue growth in last year's budget. And I mean, overall, the goal for any budget that you develop is that you hope to be zero. It's never perfect, but just so when I saw those actuals last year, we did make an aggressive assumption, which resulted in a lot of the investments we see in new investments that we are implementing in the current year. And so it actually is where I would in some ways hope our budget to be, where we're closer, we're not having $100 million variances. There is a lot of unpredictability in terms of what we do, but that's also what the management reserve is for, to help buffer and allow us to make some of those assumptions and not be as conservative. But overall, to answer the question, I think our Medi-Cal revenues are actually increasing year over year. You're just not seeing the variances because we trued up the budget. And again, and sort of based on this projection, we did also make another true up as part of our budget proposal that you saw last month for our February submission.
Actually, Commissioners, is it okay if I check public comment before we go to your comments? A person on the line, if you'd like to make comment on this item, please press star 3. Star 3. All right. No comment, Commissioners.
I had a question about the 340B program and the accreditation. Do we have any expectation that the accreditation will be coming soon? And do we have any concerns about what's going on in sort of in Congress with the questioning of the 340B program overall?
That's a good question. I worked with Dave Smith, our director of pharmacy, when I saw that shortfall related to it. He is hopeful about accreditation, and so he does expect it sometime this fiscal year. He didn't have an exact time frame, but I could get back to you to see if he has a better sense of it. Some of it is out of our hands. And then he did not note any concern regarding any of the federal issues, and he was hopeful that we move forward. But again, I will follow up with him just to confirm that.
It just seems the 340B program is a football that keeps going back and forth, and we're just wondering whether, given the changeover in the the sort of leading Congress, leading party in Congress that questions this program. Just wondering if it's something that we should keep our eye on.
Yep, it's a good point, Commissioner.
Any other questions or comments, commissioners?
I was just wondering, I think last time you had mentioned the public health lab building, and you're still mentioning it this quarter. Is there any hope, or, I mean, where are we in trying to resolve that problem?
Yeah, I'm working, I know Daisy Aguayo, our Deputy Director of Population Health, has been working between both her lab operations as well as IT on this, and sort of seeing some of it on the financial end, and so there have been several meetings, and I've been part of it just sort of seeing what I see as a symptom of some of the issues, and so I will get back to you on a time frame, so but there is some portion that's related to public health lab building, and then again, some portion just related to the change in model around adult immunization clinic, but it's still a significant amount of time.
Thank you.
We'll get you an update on that.
Thank you.
Thank you, Commissioners.
Thank you.
All right, commissioners, we can move on to item 9, emerging issues. First online, if you'd like to make comment on this item, please press *3. I don't see a hand. Commissioners, anything from you?
I had a thought as we were discussing the contracts report and the new contracts, that given that, we seem to be we don't have the full context of some of the programmatic, the contracts that we're being asked to review and approve related to an overall program. If at some point maybe the schedule could have this subcommittee and the community health committee
Community
somehow,
Public Health?
yeah, community public health committee either schedule the overview of the sort of the review of projects, the evaluation of projects, sort of in line with when we're going to be looking at some contracts related to an overall program. I don't know if that's possible, but it would help, I think, maybe to give some of that context, Commissioner Chung, that you're looking for, and that we've been questioning, just so that it's not additional work, that it actually can sort of be coordinated a little bit, maybe.
Thank you.
Yeah, that's a great question. I think that the Community and Public Health Committee is doing a pretty good job in terms of getting, like all the programmatic reports, and the staffs are used to coming in and tell us success stories, or and how it impacts our constituents. And I think that you're right, but that piece is seems to be always missing from the finance and planning side. When the dollars and cents is what we really want to know, how it is being spent and how well the return is, in terms of health outcomes. So yeah, so I think that if we can work with them and figure out a way to periodically have a department that comes in and do a thorough report.
All right. I will certainly put that request in, and it totally makes sense. I fully understand where you're coming from. I just want to speak from my experience working in that world and the contracts, that what seems to happen is I forgot the name of the contract that came up, but the city attorney took 2 years to approve. They often don't have control, and then it just pops up, and it's not like they don't have time to plan it. It just kind of rises to the top for this meeting, and so it's a little difficult to coordinate when you're talking about your effort, Commissioner, because the finance side doesn't have as much control. But certainly, I will put that forward. I wanted to give you that context, that it's not, I think, as planned as you all may think. It kind of there's a whole mishmash of contracts, and whatever they can finish in time for this meeting they do, and then the other time they do it the next meeting. If that makes sense.
It kind of makes sense, but I think that at the end of the contract periods, they should be able to tell us, how well they did, right? So, and sometimes, for instance, the soda tax, for instance, they can come in and tell us how the money has been invested, and throughout the 5 years, what actually had happened. So I think that it's not so much, when the contract is up for approval that we need to have that kind of conversations, but it's more about when they are wrapping up that contract before they have a new RFP out, they should be able to tell us, like what's the result, like,
Sure.
and, like the kind of like products we got out of business majors. So like what kind of like, services we were able to provide and how many people we actually have served.
And outcomes. And Commissioner Guillermo, I didn't mean to dispel or to put down, I wanted to give you the context. I'll certainly put that forward, but I think what Commissioner Chung is saying might be more feasible in the world that we're living in right now.
Yeah, and, whatever works in that regard, I think that it would help us in this committee to have that context whenever it is appropriate to have it. And I think what you're suggesting, Commissioner Chung, in terms of sort of the wrapping up of a long-term contract makes sense, because it doesn't always coincide with what the community public health committee is, or even a presentation here at the full commission. And it shouldn't, hopefully won't take a lot more work. It's really more, as I think Commissioner Chow had suggested, that maybe it's a paragraph or so, or maybe a chart or something like that, of data they already have that doesn't require different, analysis. But I am interested in outcomes related to, and that might be more work, because I think the contracts aren't necessarily designed to measure outcomes. They're designed to measure units of service. And so that might take a little bit more work over time.
Yes. Well, I also, again, there's no one here from that world, but I do know that all the contracts do have outcome objectives. It's part of what's required. And so I think it's just not being reported to you all in the ways that are helpful to you. But so I'll do some digging, and hopefully even possibly in the future have an item on the agenda where you all can have this discussion and have it a more fruitful discussion with the people who actually work in that world, so it's better represented. But I'm noting it, and thank you.
Yeah, and actually that's another point that, like we are having these conversations because we're moving to discussions about health equity, so without things that we can measure, how are we going to discuss equity, on the commission?
Well, and behavioral health has actually helped us already in providing us that information, as you were saying, the outcomes for the next contract. And so perhaps that's a good model in terms of being able to give us back that information without having to rewrite it, but send in a format, because I think that's been very helpful for us to understand with the behavioral health contracts, what's been happening, what they've been doing with the clients, and then what they've been doing with the suppliers and so forth.
Okay, thank you for that.
And those two contracts, the Sugary and the NICOS, are things that certainly had outcomes, and we're asked to fund it for another year, but we've been funding the gambling program for 15 years. And I'm sure that there are some successes they would like to tell us about.
Oh, I'm sure, right. No, again, it's just not being brought to you. Of course there's outcomes that
Yeah.
exist. I mean, that's part of what all the DPH contracts require, that the city requires that from the
Right,
controller's office.
and that's the whole thing about, as you said, the city is quite concerned about the large programs that we're funding, and financially, there are those issues that we're going to hear about later, but we also need to know the outcomes.
Right.
Yep.
So commissioners, thank you for this. I'm a little concerned about getting the SF TV folks back. So they
Yeah,
can
so we'll
follow.
entertain a motion to adjourn.
Yeah,
So
well,
moved.
actually, there's item 10 is public comment. I want to note the person online, if you'd like to make general public comment, please press *3, item 10. This is your time. All right, there's no public comment, so please consider adjournment.
I'll move adjournment.
Al, second?
All in favor, please say aye.
Aye.
The meeting is now adjourned.
Thank you.
And where are we all moving to?
Give me 1 second.